Hi, everyone. Welcome to today's webinar, Data Drives Decision, Healthy People 2030 and Dementia. My name is John Sheehan. I'm one of the Associate Directors for the Healthy Brain Initiative here at the Alzheimer's Association. And I'm so excited for you to join us today. I hope it's an informative time. Today's webinar is designed to discuss the Dementia Objectives of the Healthy People 2030 framework, including the current and planned data analysis for each of the objectives, how health equity can be advanced through those objectives, and lastly, how a state, one state in particular, is using the Healthy People 2030 framework in order to advance strategic planning at the state level. Just a few housekeeping items before we get started. As you heard right at the start of this, the presentation today is being recorded, so it's available in the future and for those that couldn't join us. At the end of today's session, after we have the recording posted, every registrant will receive a copy of the link, as well as a copy of the slide deck and related materials to today. We'll be taking all questions via the Q&A box, so please feel free to enter a question anytime throughout today's presentation. We have Q&A reserved for time at the end, and we'll take as many questions as we have time for. I would like to acknowledge, before we dive in, the Centers for Disease Control and Prevention for the cooperative agreement that allows us to have today's presentation. But please do know that the thoughts and opinions expressed during this presentation are solely those of the speakers themselves. So just a very quick poll to kind of help us get to know who you are, who's joining us today. If you would just take a few minutes to let us know what is your primary area of focus. Are you a public health practitioner? Do you work within the aging network, healthcare provider, staff member here at the association, or work in a whole different arena altogether? We'll leave that open for just a few minutes, but it does help us know who this webinar is reaching and who's joining us to learn today. And as that continues to go through, we'll dive into the substance here. Here we go. Using two different computers, trying to be smart about it, but getting a little confused myself. So Healthy People 2030, that's what we're here to talk about today. What is Healthy People 2030? What is that framework? And the way that I like to think about it, someone described this to me a couple of years ago, that Healthy People in this year's iteration, 2030, is really the nation's public health blueprint. It's really designed to help improve the health and well-being of people across the entire country. And I really like that blueprint description, because just as an architectural blueprint lays out, how would a building be built? What are the parameters? What are their specific design elements? Healthy People 2030 lays out those similar elements. How can we go about improving overall population level health and well-being through a public health approach, specifically to reach those improved health outcomes? It is a 10-year strategic plan. It contains 62 topic areas with 355 objectives. We're going to spend today talking about 3 of those objectives within the dementia topic area. But what's really unique and what's really beneficial about Healthy People 2030 is the measurement aspect. The framework establishes measurable goals within each objective specific to health promotion and health prevention. How can we collectively, through a public health approach, through the power of public health, how can we improve those health and well-being outcomes across the country in a measurable, data-driven way? At the end of this 10-year period, once we hit 2030, we're hoping to have built a better, healthier future for all. And really using those measures that we're going to talk through, using those measures to ensure that we are making that kind of progress. Just as many of us throughout the public health community have really increased attention, necessary attention, on increasing health equity, addressing health equity, reducing health disparities, Healthy People 2030 takes a very similar approach, emphasizing the attention to underserved populations, to disparate outcomes, to health disparities, addressing those directly through our power of public health to improve, again, population level health and well-being. So the 3 objectives that we're talking about today are the dementia objectives. And I'm not going to read these because we'll go through them each individually. But what I want you to take away from this particular slide here is this new one right at the bottom. The first 2, DIA1 and DIA2, are actually a continuation of objectives that were established in Healthy People 2020, the last iteration of the framework. And for the 2030 framework, is a DIA-3 objective. It's exciting to see the expansion and kind of the growth of the objective area related to dementia, because it's showing an increased attention to these issues, to this topic area by the public health community. Here at the Alzheimer's Association, as part of our Healthy Brain Initiative department, that's exactly what I like to see. I want to see more of it, but I'm glad to see this increased attention, and it gives us additional tools as public health professionals to continue that drive, continue that momentum, and continue helping those living with dementia, those impacted by dementia, those at risk for dementia, as well as their caregivers. DIA-1. This is all about diagnosis. So you see the actual text here at the bottom, which is increase the proportion of older adults with dementia or their caregivers who know they have it. The DIA objective establishes a baseline from the most recent data that we have back in 2013 and 2015 of 59.7% of those older adults with dementia report being told of their dementia diagnosis or their caregivers. And I'll explain that in just a minute. As you can see through the kind of teal bubble there, there's an increased desire to increase that proportion to hit our target population, our target number of 65.1, increasing that proportion of older adults with dementia or their caregivers who do report that they've been told of the dementia diagnosis. So how is that measured? This comes from Medicare Current Beneficiary Survey data, MCBS for short. And MCBS is a really interesting data set because it's an interview process. So there are specific questions asked to current Medicare beneficiaries. And it's a whole interview process over a 4-year period, usually about 3 times per year over that 4-year period, that asks a wide variety of questions. One of which relates directly to dementia. The question itself, has a doctor ever told you that you have Alzheimer's disease or dementia, is asked throughout that interview process. So if a beneficiary responds that, yes, I have been told that I have dementia or Alzheimer's disease, that person gets counted as knowing of their diagnosis. But you can see that's only right now that 59.7% of individuals. So where do the remaining 40%, where do they fall? And that is actually the other really interesting part of the MCBS data set, is that it's linked to Medicare claims data. So if a person that answers the question, no, I've never been told I have dementia, but they do actually have a dementia diagnosis within that Medicare claims data, that's where the difference is coming from. So 40% of that population does have a dementia diagnosis without reporting, without actually having a positive affirmative answer to, yes, I've been told about this. The caregiver component of this is due to the fact that MCBS data allows for proxy responses. So if a person is unable to answer the interview questions or elects to have someone else answer on their behalf, those proxy responses are included in the MCBS interview data. Dementia Objective 2, DIA-02, is all about preventable hospitalizations. Here at the bottom, we can see reduce the proportion of preventable hospitalizations in older adults with dementia. So the most recent data that we have on this from 2013 to 2015 is 23.5% is what the baseline that we're working with. And you can see that we're desiring a decrease among that population, hoping by 2030 to reach 19.1%. This data comes from the Health and Retirement Study. Sorry, that's a typo there, Health and Retirement Study, not survey. And HRS data for short is also similar in kind of structure to MCBS, but has different population and some different parameters. So HRS data is also an interview process, an in-depth kind of longitudinal interview process. There is opportunity to link to Medicare claims data, but since HRS, the survey population is not limited to just Medicare beneficiaries, there are additional enrollees, there are additional participants who are not enrolled into that Medicare component. And so any participant that has a dementia diagnosis or through the interview process, which has a cognitive assessment component, is determined to meet the dementia diagnosis criterion. the question then remains, what is a preventable hospitalization? And there's a few different ways to that researchers and kind of the analysts who have looked at this to actually describe what a preventable hospitalization is. And there's a slew of conditions, but these are conditions that experts generally agree can be managed successfully in outpatient or ambulatory care, and do not usually require a inpatient level of care. So these can be things like COPD, chronic obstructive pulmonary disease, asthma. This can be nutritional deficiencies, urinary tract infections. So if a person that is identified as having dementia does have an actual inpatient hospitalization, an inpatient admission with one of these preventable conditions, they are determined to be a person living with dementia who has a hospitalization that could have been preventable. And so reducing that proportion so that fewer people with dementia are admitted with preventable conditions, that's the overall goal for DIA-02. And our final objective here is on cognitive discussions, DIA-03. So at the bottom, we can see that the objective is to increase the proportion of adults with subjective cognitive decline who've discussed their symptoms with a provider. Our most recent data shows that 45.4% of individuals with SCD have actually just had a discussion with their healthcare provider about those cognitive issues. There's a desire to increase this over the next 10 years to reach a target goal of 50.4%. The data source for this comes from the Behavioral Risk Factor Surveillance System, or BRFSS. And this is a state-based data collection survey that's administered annually through each state. And this particular data comes from an optional module called the Cognitive Decline module that assesses for subjective cognitive decline. SCD is a measure of most frequently characterized as an increase in memory loss or confusion that is happening more often or getting worse over the past 12 months. And SCD is often one of the earliest warning signs of future dementia risk. And so identifying individuals that have SCD that self-report they're experiencing these memory difficulties, these memory issues, encouraging them to have discussions with their healthcare provider about those cognitive concerns. That's the overall goal for DIA-03, increasing those discussions so that earlier detection and diagnosis can occur, and that more care and support can be provided should someone be diagnosed with cognitive impairment or later dementia. Before I turn it over to my colleague, I just want to mention the Healthy Brain Initiative Roadmap, which actually provides a structure, a framework, a roadmap, if you will, for public health officials at the state and local level to really incorporate and increase attention to early detection and diagnosis, risk reduction, caregiving concerns, this public health approach to Alzheimer's, to dementia, to cognitive health and caregiving. And the HBI Roadmap has a flexible agenda of 25 actions for those state and local public health agencies mapped to the essential public health services. And actually two of the objectives, I would say, align really well to using Healthy People 2030 data. M3, using data to inform public health program and policy response, as well as M2, which supports the national national data collection on related issues. So if you're one of the public health practitioners on the line, consider incorporating Healthy People 2030 into larger initiatives, larger structures, larger planning efforts that you are accomplishing within your agency. And we'll hear a great example about this in just a few minutes. But do want to call attention to the Healthy Brain Initiative Roadmap as one of those guiding structures. And with that, I am very pleased to turn it over to my colleague, who's going to walk us through our next section. Megan.
Hi, everyone. So in addition to all the important points that John shared, we also want to make sure to highlight the ways that Healthy People objectives can be used when addressing disparities in dementia. And broadly speaking, on the next slide, you can see that there's some widely recognized disparities, including when it comes to prevalence of the disease. For example, almost 2/3 of Americans with Alzheimer's are women. We also know that there are racial and ethnic disparities. So older Hispanics, for instance, are about 1.5 times as likely to have Alzheimer's or other dementias as older white Americans. And older Black Americans are actually twice as likely to have Alzheimer's or other dementias as older white Americans. We also see disparities when it comes to diagnosis and care. So if we look on the next slide, and to share just one example, Although Black Americans are more likely than white Americans to have Alzheimer's or another dementia, studies show that they are less likely to have a diagnosis. Delays in diagnosis can mean less likelihood of getting treatments when they are most likely to be effective at improving quality of life. We know that early detection and diagnosis can allow for earlier use of available treatments that may provide some relief of symptoms and help maintain independence longer. Delays in diagnosis also mean that those with Alzheimer's and other dementias may miss the opportunity to make important legal, financial, and care plans while they are still able to make their preferences known to their families. On the next slide, when we look at the evidence from the Healthy People data related to diagnosis and care, we're able to track progress not only by the overarching goal, but we can also look at the data from a health equity lens. For this particular example, we're looking at data, a snapshot of data from 2013 to 2015 from the Medicare Current Beneficiary Survey, and have it divided by race and ethnicity. Whereas for white Americans and Hispanic Americans, the percentage who reported awareness of a diagnosis was over 60%. For Black Americans, only 52.5% reported awareness of a diagnosis. So as health departments and partners work to address diagnosis efforts through focusing on clinicians, health systems, and public awareness, this measure can be used over time to see how and if we're moving the needle when it comes to diagnosis disclosure for people of various races and ethnicities as well. On the next slide, similarly, I'll share an example from the objective on preventable hospitalizations. So based again on Medicare administrative data here from 2013 to 2015, preventable hospitalizations represented a shocking 23.5% of total hospitalizations for individuals with Alzheimer's or other dementias. And we can see from the chart that Black older adults had a substantially higher proportion of preventable hospitalizations at 31%, compared with Hispanic and white older adults who were at 22% for each group. So here again, this is something we can and should track as we aim to shift towards more effective and higher quality care for all people with dementia. And we can shift to the next slide. Due to our brief time together, the examples I've shared are largely focused on race and ethnicity, but please know that there are many ways to cross-tabulate the data, including, for example, by geographic location, which can impact access to care, especially when we think about our rural populations, for example, along with health insurance status and a whole host of other various communities, which you'll see included on this slide. The big takeaway that we want you to consider is that data from Healthy People Objectives allows us to track not only towards the overarching goals, but also progress towards eliminating disparities in dementia diagnosis and care. And now I want to turn it over to our wonderful colleague, Chuck Duarte, who will share an example for the use of Healthy People Objectives in Nevada. Thank you.
Thank you, Megan, and good morning, everybody. Thanks for joining us. Again, my name is Chuck Duarte. I'm the Policy and Advocacy Director for the state of Nevada. And I want to just give you one example of how we've used Healthy People 2030 in our efforts to reduce the impact of Alzheimer's disease and other dementias in our state. Next slide, please. So, we have a couple of things that we're working to our advantage, and I'll talk about several of them. One is that we had our legislature recognize the importance of addressing Alzheimer's disease. And so as far back as 2011, they established Assembly Concurrent Resolution 10. And what they did was they created a legislative committee on healthcare to develop a state plan to address Alzheimer's disease. The committee included senators and chairs and medical advocates, as well as key stakeholders, and developed a state plan to address Alzheimer's disease, which was published in early 2013, just prior to the next legislative session. And then during the 2013 legislative session, Assembly Bill 80 was passed, which actually established the Task Force for Alzheimer's Disease, which is responsible for implementing the state plan. Next slide, please. So we had several advantages, as I mentioned, and one of them was an obvious example in that we were working in silos. And I'm sure this is the same as it is in many other states, but most of our senior care services were housed in our aging division. It's the Nevada Division of Aging and Disability Services. And then most of our public health initiatives were in the Division of Public and Behavioral Health, another silo. And one of the advantages we had was that our task force was chaired and we had members who had experience in public health and as well as minority health issues. And so they were very interested in seeing how we could bridge the gap between aging services and also our public health initiatives. And one of the things that we did, I did a survey of 30 state health improvement plans across the nation, including our own in Nevada. And there was absolutely no reference to the two Healthy People 2020 dementia, including Alzheimer's objectives that were housed in Healthy People 2020. There was no mention of those initiatives to address Alzheimer's disease in any state health improvement plan that I reviewed. And so that provided a compelling backdrop for the task force on Alzheimer's disease to look at how we can fix that and how we can more aggressively bridge that gap between silos. And so we worked on updating the state plan. And so that was a part of the effort that we undertook. So next slide, please. And so over the last year or so, we were working on updating the state plan for the 2022 version of the plan. And what we did was we included an introductory section specifically on Healthy People 2030. And we wanted to recognize it, as John said, as a public health framework, but also to make sure that we included dementia as a part of that framework. And so we gave a preamble explanation of what Healthy People 2030 was and some of the measurements, some of the goals and objectives that were included in that project. And as you all know, DIA3 is one of those measures that we can actually see at the state level. We can get data at the state level through the Behavioral Risk Factor Surveillance System Cognitive Decline Survey. The other two are really difficult to get state level data. I'm hoping at some point in the future we can, so we can all collectively look at how our states are doing. But certainly DIA3 was one of those objectives that we could measure and get data on an ongoing basis. And so we included that in the preamble as well. The other thing that we had going for us, as I mentioned, was that we had several folks from a public health background that were part of our task force. Our chair works for the University of Nevada, Reno School of Medicine. We have a member who's a professor of public health at the University of Nevada, Reno. And we also have the director of the Nevada Department of Health and Human Services Office of Minority Health. And so, you know, with that background, we were able to include some of the language around Healthy People 2030 in our task force state plan. But the other thing we have is that we have the BOLD Act. And I think a lot of other states also have BOLD Act funding. And the other advantage here is that the BOLD Act was subgranted from our Department of Health and Human Services to the UNR School of Public Health, and specifically an office in that school called the UNR Dementia Engagement Education and Research Center. And so they're actually implementing the provisions of the BOLD Act grant as a part of it, and very interested in bridging some of those voids between aging services and public health. And as a part of the BOLD Act, the UNR, they call it the UNR DEAR program, also runs the Dementia Awareness Campaign for Nevada. And they work with Dementia Friendly Nevada as a way of reaching the grassroots communities to make sure that our message is getting out. And then finally, we have an awareness campaign that actually started back in 2019. The Nevada Department of Health and Human Services awarded a grant to the Alzheimer's Association of Northern Nevada and Northern California to run a statewide awareness campaign to increase the awareness around early detection and diagnosis. And so we used assets from an existing program, a great set of media assets called Know Where Alzheimer's Hides. And we used it to fund a media-driven campaign. And that was re-awarded to the Alzheimer's Association, Northern California, Northern Nevada chapter this year for 2021. And so we're very pleased to have that message continuing to go out as a part of our public health initiatives. And I think that's it. Next slide, please. So we're all available for questions and answers, and hopefully we have some. So again, thank you very much for your attention.
Yes, thank you so much. And thank you, Chuck. Thank you, Megan, for walking us through all of that. Just to provide a little bit of takeaway and kind of why I wanted to highlight the Nevada example on this particular webinar is I think through my years working in public health and working with state agencies, working with local agencies, understanding kind of the barriers and roadblocks to driving attention to any given issue. Everyone that I've talked to in the public health world has always recognized the need, the desire to work on Alzheimer's, dementia, caregiving issues, but hasn't necessarily had the infrastructure or the push, the impetus, the ability to drive that attention. And so by elevating DIA 03, for example, to a state strategic plan as Nevada did, it brings that whole population level approach. It brings that public health approach and kind of drives the actual implementation, the attention necessary in order to move the needle on that particular objective. So I love that example because I think it's really illustrative of how public health agencies can use the existing infrastructure within their agencies to really incorporate additional attention, continued attention to Alzheimer's, cognitive health, and caregiving issues. So we do have just a few minutes left before the close of our short coffee break webinar today. And we've answered quite a few questions in the chat. But if we don't get to any today, we'll follow up with individual respondees or individual attendees after this with responses. A few questions that I'm kind of coalescing around and want to give a little bit more clarity to are the actual data sources that I used and kind of went through describing each of the objectives. So as we heard with Chuck's presentation, DIA3 has a state-based, a built-in state data set through the behavioral risk factor surveillance system. So it's easy for a state at the state level to look at DIA3, see what the progress is, see what the objectives are, incorporate that into strategic planning. The other two objectives, DIA1 and DIA2, are nationally representative data sets. They unfortunately are not representative at the state or sub-state level. So it definitely makes it more difficult for an individual state to assess what their progress is from those data sets. There is a way to do it, and I know that the UNR center that Chuck talked about has attempted to put some time and effort into it, but it is challenging from that front. So recognizing the value of DIA 1 and 2 as an overarching framework when I'm looking at an individual state is helpful, but that DIA 03 has that built-in state-based data set that can easily be incorporated. Another quick question that I do want to update on is just the capacity. How does Healthy People 2030 assess progress? And Megan answered this in the chat, but to elaborate just a little bit further, for each objective, there's a corresponding, there's a baseline estimate. There has to be at least one mid-course, is how they call it, mid-course data analysis, and then the analysis at the end of the decade. So that there's at minimum three points throughout this 10-year period where the data are analyzed, are assessed to see what the progress is. Are we meeting that increased desire, either up or down? Are we meeting that direction, either increased or decreased? Or are we going in the wrong direction? So there's at least 3 points throughout the 10-year period where that's assessed. Individual objectives, depending on their data sources, can sometimes be easier and more frequent, but a minimum of 3 times throughout the 10-year period to see what the progress actually is. So I know there's a lot of technical questions. There's a lot of really great discussion that's happening both in the chat and in the Q&A. So we'll follow up after these today with any questions that we didn't get a chance to answer. But thank you so much for joining us today. If you wouldn't mind, I'm going to, in the chat, put a link to a very quick feedback form. It should take not even 2 minutes, but if you do have an opportunity to give us some feedback, it helps us make sure that we're tailoring and meeting the needs of you as participants with the information that we provide. So I just wanted to thank you so much for joining us today. We will send out a link to the recording, a copy of the slide deck, as well as any associated materials within the coming week. Thank you so much, particularly for this short coffee break webinar. We hope you have a wonderful rest of your day. Take care, everybody.